my thumbs up. Okay, I guess I can start. So I'm Dr. Jeff Postma, and what I'm going to talk to you about is knees designed for you. So a little bit about my background. I'm a Michigan native. I was born and raised in Holland, Michigan. I went to Holland High School. From Holland, I went to East Lansing and was a Spartan for 14 years. I went to Michigan State for 14 years because my undergrad was there, my medical school, and my residency was associated with Michigan State. So I went to Michigan State's College of Osteopathic Medicine, and then I did my residency in Flint, Michigan. It's known as Genesis Regional Medical Center, largest facility in Flint. My orthopedic career, I've been practicing since 1997. I started out in South Haven. We talked a little bit, I've done over 1,500 joint replacements, that's knee replacements. I work at Community Bone and Joint. Our office is located in Coloma, and I'm associated with Lakeland Hospital, and I do all my surgeries right here at this hospital in Watervliet. So kind of a little bit of preview about what we're going to talk about is talk to you a little bit about the basic knee anatomy, a little bit about arthritis, signs and symptoms of arthritis, what a knee replacement is, and then really kind of the meat of the topic, talking about what is designed for you. And these are terms that are kind of being thrown around a lot right now, and actually the FDA is going to regulate what terms we can call these things. And I'm going to talk about patient-matched blocks. So this is matching the cutting instruments for your knee, and then custom implants. This is an implant that is custom built based on your knee. So I don't know if anybody ever watched the TV show How It's Made, and I thought this was a really good episode. So I'm going to spend a few minutes kind of watching this video.
The typical candidate for a knee replacement has osteoarthritis, where the cartilage in the knee has worn away. Knee replacement surgery restores the worn areas with an implant, and to help place that implant properly, the surgeon can use an instrument custom designed for the patient's damaged anatomy. A successful knee replacement depends on its alignment with the femur and tibia, the upper and lower leg bones that connect at the knee. That's a challenge because knee implants are standard while every patient's bones are unique. So, starting with an MRI scan of the patient's knee, this medical device company produces custom-made surgical templates. Plastic devices the surgeon uses to sculpt the surface of the patient's bones to align the knee implant accurately. The surgeon no longer has to visually calculate the bone cuts on the spot in the operating room, which takes more time and is more invasive. An engineer uses the MRI scan to create 3D models of the patient's femur and tibia. The patient's cartilage has worn out in between these bones, causing painful rubbing that erodes the bone surface. The implant effectively replaces the damaged bone and cartilage. Once each bone model is ready, another engineer applies a 3D model of the correct size implant. Then, following directions the surgeon has provided, performs virtual surgery on the bone model to properly align the implant to the patient's specific anatomy and fit it to the angle at which that particular knee moves. During this surgery simulation, the computer records every bone cut. Only once the surgeon reviews and approves this surgical plan does manufacturing begin. The computer which recorded the bone cuts guides a 3D printer to produce plastic templates for both femur and tibia, which the surgeon will use to repeat these exact same cuts in real life. The 3D printer applies a layer of powdered plastic, then, following the computer model, solidifies select areas with a laser. This process keeps repeating, building up the shape of these surgical templates layer by layer. One printer run produces personalized templates for up to 50 patients at a time, so the laser inscribes the patient's name and identification code on each part. Once the printing's done, it's just a matter of breaking up the unsolidified powdered plastic. and fishing out the templates. They brush off the bulk of the remaining powder. The posts on the bottom are the points at which pins affix the template to the bone during surgery. Next, the templates go into a tumbler containing plastic balls and air jets. As the drum rotates for 20 minutes, the balls knock off and the air jets blow off most of the remaining powder. The templates exit the tumbler 90% clean. They go through 2 wash cycles to remove the last remnants of powder. Before packaging, they'll be sterilized. But first, every template must pass a quality control inspection. Using a laser, a technician scans it to make sure the manufacturing process produced an exact match to the patient's bone, as per the computer model. This model shows how the femur and tibia form the knee joint, and how the surgeon secures the customized template onto each of these bones. Thanks to these devices, the surgeon doesn't have to figure out the bone cuts on the fly in the operating room. They're all pre-calculated by the computer model. This method eliminates several steps required in standard surgery. Therefore, the operation takes less time and requires half as many instruments to set up and clean up. And because the surgeon no longer has to drill a hole in the bone to check the knee implant's alignment, the patient experiences less pain and bleeding, which means less likelihood of developing complications such as blood clots.
So this is what we kind of consider really a computer planned knee, and it won't stop. There. So that's kind of the basis of what I'm going to be talking about. That's just one company's, and that's a TV show, how it's made. My kids love watching it, and they were like pretty excited when they saw that, and then I was able to find the video for here. So a little bit about the basic anatomy of the knee. You know, we have kind of 3 basic bones of the knee. We have the femur, which is your thigh bone, and the tibia, which is the shin bone, and then the kneecap. The rounded ends on the bone are called the condyles. This is the condyles. That's what helps distribute the weight when you're standing, and that's what provides kind of the smooth motion of your knee joint. You have ligaments in the knee. The ligaments run from bone to bone. That's what kind of holds the knee together. And then you have tendons, which run from the muscle to the bone. And then cartilage. Cartilage is what covers the ends of the bone. That's the cushioning property that you have inside the knee. The cartilage, there's 2 different types of cartilage in the knee. There's articular cartilage. That's the cartilage that covers the ends of the bone. With arthritis, that's the cartilage that wears out. It becomes thin. My analogy is it's like a car tire. You know, you drive your car 80,000 miles, the tread becomes thin. Same thing happens on the knee joint, is that cartilage starts to thin out. The other type of cartilage is called the meniscus. It's kind of like a little O-ring that's in your knee. And that helps provide a little bit of support, provides a little bit of cushioning inside the knee. Sometimes people have a torn cartilage to their knee. That's the meniscus that we remove. So both of them protect the ends of the bone. Both of those can be damaged inside the knee. So from an arthroscopy, a knee scope, we can look at the cartilage. This is a normal cartilage. So it has normal cartilage on the end of the thigh bone and normal meniscus. So no arthritic change. And then when we look at an arthritic knee, you know that white glistening, it's no longer smooth. You actually see kind of bone here and then loose pieces of cartilage, and this is kind of real frayed. So it's sort of like the the tire going down the road that's lost all its tread, has the cords showing. That's kind of the bone being exposed. Arthritis. Arthritis is defined as an inflammation of the joint. There's over 100 different types of arthritis. The one that we know most is osteoarthritis and rheumatoid arthritis. That's the most common forms. It affects 43 million Americans a year. So it is a very common disease. Causes pain, swelling, and loss of motion. All the things that we don't like. We want to not have pain into the joint. We don't want to have the swelling because that can lead to the pain. And certainly we want to maintain our motion to a joint. 1 in 6 people are disabled because of arthritis. So it's a chronic problem. And like I said, the 2 primary types are osteoarthritis and rheumatoid. So osteoarthritis, osteo meaning bone, and arthritis. So it's a disease that directly affects the joint. It affects the cartilage of the joint. It is a wearing of the cartilage. Osteoarthritis, I always describe it as a wear and tear of the joint. So 23 million Americans suffer from osteoarthritis. And you know, the projection is that by 2020, that almost double that amount will be affected. Osteoarthritis usually starts as a very small area and then progressively becomes worse. So it's a progressive type problem inside the knee joint. It can involve 1 compartment of the knee or 3 compartments. And what we mean by that is that on the outside of the knee is called the lateral compartment. The inside of the knee is the medial compartment. And then underneath the kneecap, the patella, is the patellofemoral compartment. So that's the 3 compartments. And that kind of comes into play with what options we have for a knee later on. So eventually you wind up having bone-on-bone contact with osteoarthritis, resulting in the pain, the swelling, and the stiffness to the joint. So the symptoms of arthritis: painful, swollen joint, loss of motion to the joint, having the stiffness, leads to somebody having decreased activity, having an impaired lifestyle. Can't get out, can't run, play ball, can't do the things with the grandkids, can't get on the bike and ride distances, walking through the store. All those things make a big difference in your life. And then it leads to joint deformities that, you know, people are really bow-legged or real knock-kneed because of the wear changes there are to the knee. Osteoarthritis. When we look at an x-ray, kind of a normal, healthy knee has joint space here. So that's the dark space. That's where the cartilage is inside the knee joint. As you get progression of the disease, you wind up getting a deformity. And in this case, you wind up opening up this side, stretching the ligament on the inside of the knee, and really bone on bone, and actually kind of a wearing away of the bone on the outside of the knee. Conservative things that are done with arthritis. Conservative things that we can do. We can exercise. So we always say you lose it or lose it. You know, it's maintain the motion to the knee. Otherwise, you wind up getting more stiffness to it. Lifestyle changes. Become more sedentary. You know, not what we typically want to do. Diet and weight loss. For every pound, there's about 7 to 8 pounds of force on the knee joint. So losing weight is always one of the conservative things to do. Rest, heat, ice, those things can help with the swelling and the inflammation. Medications, lots of different medications. There's hundreds of anti-inflammatories, the Motrin, Advil, ibuprofen, Aleve, naproxen, and a lot of prescription anti-inflammatories. Medications for pain, Tylenol. Other supplements. We heard a lot about glucosamine, chondroitin sulfate in the past as helping to build cartilage. It works to decrease the inflammation to the joint. Braces, that helps to limit range of motion. maybe correcting some deformity to the joint. Using walking aids, a cane. Using a cane, we can reduce the pressure on the joint by over 30% by using a cane. Doing injections, whether they do a steroid injection or we do a viscosupplement injection. That's an injection of a thick fluid that we inject into the knee joint, provides a little cushioning inside the knee. And physical therapy. They help with exercising, maintaining strength, maintaining motion of the joint. So a knee replacement, what is a knee replacement? Personally, I never really liked the term replacement because it kind of gives a connotation that you cut the joint out from here to here and replace everything in between. A knee replacement is more of a resurfacing of the joint. We keep the ligaments, we keep the muscles, we keep the tendons in place so that it has more of a normal feel to it. And so when you have a really degenerative knee, what we do is we cut off just the degenerative portion. We remove just a sliver of that bone. And then there's an implant. The implant is kind of a cap that fits on the end of the thigh bone, a tray that fits on top of the shin bone. And then those two are implanted onto the bone to provide kind of a natural feel or a natural motion to the joint. So why is a knee designed for you? And with designing a knee that's specific for someone or having a computer planned knee, and that's essentially what we're doing is we're planning ahead of time the best position for the implant. It's because over 30% of knee implants can fail because of malalignment, that it's not put in a correct position. Somebody was asking me about, number of repeat knees that I've done, and I said, if I want to say a little tongue-in-cheek, that I haven't done a lot of my own, is because a lot of it is the planning that you do ahead of time to make sure things are in proper position. Having patient-specific alignment may result in a better outcome and better long-term outcome of a knee implant. So, we look at the mechanical axis, anatomical axis, and making sure that things are kind of in a proper position for the implant. So we have a couple different options. If we talked about, I said that, our osteoarthritis can start with one side, one part of the knee, and then progressively cause arthritis to the other parts of the knee. If people have arthritis to one part of the knee, called unicompartment, there's a patient-specific solution, and it's called Conformis. The company was kind of unique in that they actually conform the implant right to your anatomy, and the MIS is minimally invasive surgery technology. So the advantages of that is it's a personalized fit. It's custom fit. Your implant isn't going to fit anybody else's. It's going to fit you and you only. We can use a smaller incision for that, which means that there's less soft tissue, so less cutting of muscle, less cutting of the capsule to get into the joint. We replace only what's needed. So there's only that one part of the knee that's bad, that's the only part we replace. So we preserve options if you have to have a future surgery with that also. So a partial knee replacement. It's estimated that 20 to 40% of the knee replacements done in this country are total knee replacements, so we replace everything, and those could be partial knee replacements. Patients that have partial knee replacements, so that's a unicondylar, a partial knee replacement, compared to a total knee replacement, a lot of those people are a lot happier with a partial because they have more of a normal feel to the knee, and we eliminate pain just from that section of the knee. It preserves the ligaments to the knee, so the anterior and posterior cruciate ligaments. It preserves more bone, more cartilage to the knee, So we're leaving the cartilage in areas that don't need to be replaced. It's considered less invasive, so we have less blood loss. It's a smaller incision. Usually it's a little quicker surgery. So that means that there's a faster recovery from that type of surgery. The disadvantages of a partial knee replacement is that the other two compartments can eventually wear out. So you can have a progression of the arthritis when half the knee is replaced. So that has shown that in the past, a partial knee replacement, people had to be revised. They had to be revised to a total knee replacement at some time of their life. There's been a lot of partial knee replacements out in the past that were kind of advertised as a bridge for a while, so that you have your partial, and then years down the road, when that wore out, then you could have a knee replacement. So sometimes that's a philosophy of some of the partials. Conformists, the philosophy is we get it in your anatomical position, we make it just like your knee. You know, hopefully that's the last procedure you need. But those are possible disadvantages of a partial.
Now, if you had one compartment that's really bad and another one is showing signs, would you go ahead and just do both of them at the same time?
Yes. Yeah. So if there is, so the question is that if one is really bad and you show signs in another, do you replace both compartments? Yes. So, you know, the reason to do a partial is having wear just in the one side of the knee. You know, people are not happy with a partial when they have wear in other areas of the knee. So we kind of make sure of that before we go forward with getting a custom-made prosthesis for you. It's not something that's done on the fly. So the unicompartmental knee replacement I use, it's called an iUni. So I was kind of, it's specific for you. It is the only patient-specific implant that's on the market. And it's a custom fit. It's designed to mimic the natural anatomy, the natural shape of the knee. So it provides a little bit more of a normal function to the knee joint. Usually it's less trauma, it's fewer bone cuts, so we preserve as much bone as possible. And you know, when this comes to us, you know, it's custom in a package, and they even provide custom instruments to put into that knee, to put that implant into the knee.
So how does the insurance companies look on this? Is this something that they work with you both?
Mm-hmm. Yep. Usually it's not a problem. You know, a lot of insurance companies pay us based on what we call a DRG, a diagnostic related group. So whether I do a partial, whether it's this or any other, it's pays out the same. So you know, I guess if it costs us a little bit more for this, then we wind up kind of eating that difference. But that's a whole big scheme of things that has to be worked out.
Thank you.
So the conformist process of what's done is it starts with getting an imaging. They get a CT scan. The CT scan is a request. We send that into the company. They make a 3D image of your joint. And from that 3D image, they wind up making an implant jig, very much like that video. They do the same technology. It's a 3D printer. They make this 3D printer with this powder and the laser that actually hardens it, that's specific for each person. And then from that, they wind up making the custom implant, and then they wind up delivering it to us. And when they deliver it to us, they deliver it with the implants, the instruments, and options for implanting. Kind of the drawback is that it's a 6-week process from the time we get it registered to having the implant made. So a little delay in the process, but it is custom at that point. When it comes to me, or before it's actually made, I get a preview of what they think is right, what the engineers think is right, and if I have to tweak anything to make sure that it's in perfect alignment. So they send me where the wear is, it shows me how much wear is on the end of the bone, if there's wear in other areas. So this one, the green shows that there's maybe a little bit of a spur on the other side, but there's no spurring along the other side of the knee. There's just kind of significant spurs and loss of cartilage on the inside of the knee. And then it shows me where my implant would actually sit on it and what it would look like once the implant is in. So we get all this planned ahead of time, and through the process, I get emails and having to look at it on the internet and then sending it back before they actually push the button to make the implant. So the results of a partial knee replacement, there's significant wear on the one side. We do the replacement. With that, we have complete coverage on the end of the bone. So the whole bone is covered with the implant. Same thing on the tibia, the shin bone. You get complete coverage. So that reduces the chance of the implant subsiding with time or changing its position. We have the optimal alignment. So it's in the perfect alignment for a person's joint, so the ligaments are perfectly balanced. And we have the perfect fit. There's no notching, so there's no cuts in abnormal position of it. So hopefully this is what makes it last longer when it's implanted. Also, we have the limited bone cuts. By having limited bone cuts, it preserves bone, that if something does need to be done in the future, it is what we consider kind of a standard knee replacement after that point. So it's a patient-specific solution to arthritis of the knee. Going on to totals, there is patient-matched technology. The patient-matched technology is sort of like what the video is, and it's called Visionnaire. And it creates a vision of what your knee looks like, and it gives me the cutting blocks to make the appropriate cuts in the perfect position based on your anatomy. So these plastic pieces come back to me, and in surgery, they fit right on the knee joint. They kind of lock right into position, and on it, I have already planned what size implants best fit the knee joint. If there's an abnormal alignment to the knee, this corrects that abnormal alignment. Yeah.
What's the resolution of that? In other words, how accurate can it be?
How?
The resolution of, say, the MRI?
I guess the MRI's resolution is extremely accurate. We can see cartilage on the MRI, and then when it's sent to the engineers, just because it's, MRI is a magnetic resonance imaging. It's computer-based, so you can run a program and have it subtract out other things. So we subtract out the bone or subtract out the cartilage, so you're left with just the bone, so it's a perfect fit. And I did yesterday. Yesterday I did one of these for someone who had an extreme deformity to the knee. And when you open these patient matched, it goes on the end of the bone, it matches perfectly, we pin it, we make cuts through that. At the end, you look at it and, sometimes you have to trust what you planned ahead of time. You can't go back and say, boy, I don't know if I should do it that way. You trust your implants, and I made the cuts. And the cuts look really quite abnormal, but so did her knee. And once you put the implants in, it's a perfect alignment. So it's really amazing how closely matched these are.
Say, for example, you lose a substantial amount of weight. implant loses stability?
No, because you're not losing weight off the bone at all. The bone stays the same size.
Oh,
Yeah, and you're not changing that. So the Visionnaire is patient-matched technology. Uses your X-ray, so we do an X-ray for alignment. We use an MRI so that we know how much cartilage is there and what the bone shape is. It's a custom cutting block to make the exact cuts on the end of the bone. So it provides pretty much a custom fit of the implant. This is what I get when it comes. So it comes to me with this custom, the patient-matched block. I know what size, so we limit the amount of instruments that we need open. We know what implants we're putting in, so we kind of have all that ready. And with that, you know, our surgical time is a little quicker, and that hopefully the recovery is quicker after that. So why is it?
Those are just patterns for your cut.
Yep, those are patterns for my cut. Normally with kind of the traditional knee, we drill a hole in the bone, we put an alignment rod in, and then from the alignment rod, then we put a metal cutting block on, and then we size it during surgery to put another type of block on. So it's a cutting guide is what we're using. So it's not just a freehand cut.
I'm too old to have surgery. And I understand there's something new doing something with the nerves in the knee. Is that possible?
I don't know of anything that they do with the nerves in the knee. But I can talk to you a little bit afterwards about some of the conservative things that can be done with the knee. So, you know, why is custom kind of important? It's important is that, you know, it eliminates time in the operating room, eliminates time under anesthesia, so it reduces the risk of infection. Precise alignment. It's computer planned. We know the alignment that it has to be in. So hopefully a longer lasting implant. Visionnaire, the company is Smith & Nephew. Smith & Nephew actually they're the only company can advertise their knee implant as a potential 30-year implant that can last up to 30 years. So reducing the complications from surgery, reducing blood clots, those are all possibilities with having Visionnaire. So a knee replacement, it's taking the damaged portions of the femur, the damaged cartilage, cutting that out. So the end of the femur, you have the damaged cartilage. We make cuts, we remove the damaged end, allow it to fit the prosthesis. So the implant is kind of shaped that way. And that once we make the cuts, the bone fits right onto the end of the implant. With a knee replacement, what can be expected? Typically, people are out of the hospital 2 to 3 days after having the implant. They start rehab immediately afterwards. Immediately after the surgery, the day after surgery, we get you up fully weight-bearing on the knee and starting range of motion. People usually start out with a walker. We progress that to a cane, usually within 2 to 3 weeks after surgery. Long-term results really depends on a person's rehab afterwards. You know, you have to work to, you know, I always tell people I work really hard for a couple hours in surgery to get the implant in a perfect position, and then it's really up to you to work for the couple of weeks to get the range of motion, to get the strength back, to get back to doing things. You know, a couple of people that I see in the audience that have had knee replacements can vouch for that. By 6 weeks, most people are able to engage in their typical activities of daily living, doing the things they want to. I always tell people that with a knee replacement, it takes 6 months to a year to be 100%. You know, there's still pain from the incision, there is pain from kind of getting that motion, from being able to kneel on the knee, their scar, the scar that they have to kind of overcome to get to that point. The more physical activities are able to be done by 3 months. You know, I know that a majority of the people that I do, by 3 months, they're golfing, they're riding a bicycle, they're doing lower impact things right away. And that's perfectly fine to do.
You only have to do a partial. Is that time, same?
The time sped up a little bit, yes. You know, I think I always use the standard. It is 6 months to a year to recover. There is scar tissue. With a partial, I see people going back doing things quicker with a partial replacement. So there's less time. There's certainly less time with a walker, less time with a cane after the surgery. Yeah.
I have a friend that had a double knee replacement.
Mm-hmm.
And in doing so, she knew that if she had one done, she'd never have the other one done. So she had them done at the same time. But do they wear out after a period of time?
Well, and I think that's what we talked about with the knee replacements. You know, in the past, we always said a knee replacement would last 10 years. That's, you know, when I first got into orthopedics, that was kind of the standard answer, is that a knee implant would last 10 years. Since then, you know, our materials have changed. The plastic insert in between is not, you know, just a recycled milk jug. It's cross-linked. It's called Visionnaire, and that the plastic is cross-linked. It has a harder surface on it. It's smoother. The metal implants, there is the traditional cobalt chrome stainless steel. The other type of implant that I typically use is called oxinium. It's a zirconium metal. The zirconium is very close to titanium. With zirconium, they actually drag it through a bath of hot sand at 600 degrees and blow oxygen at it, so they oxidize the outer surface of the metal. Well, zirconium oxidized is called zirconium oxide, which is ceramic. So the outer surface of the metal is actually turned into a ceramic coating. So it's a smoother surface on the metal. That's important because if anybody ever works with any metal, if you take it and you scrape metal and rub your finger over it, you'll feel that when you scrape it, the extra metal doesn't just flake off, it creates a ridge and a valley. So when that ridge and valley runs against plastic, it's going to cause more wear. Versus if you have zirconium, or the zirconium oxide, the oxinium, when you scratch it, that ceramic surface flakes off. It's still smooth. You have a little bit of a valley, but it's still smooth. So when that runs against the plastic, it causes less wear to the plastic insert that's in the knee. So from that, they can say that their implant potentially can last longer. You know, none of these have been implanted 30 years because we haven't had this out for 30 years. So we run it on a simulator. A typical knee, I talked about beforehand, is a typical knee cycles about 1 million cycles a year. So that's bend straightened 1 million times a year. So the FDA has always required that they run it on a simulator for 15 million cycles, say, and to publish how much wear there is after 15 million cycles. Well, when they developed this oxinium metal and the plastic, their Visionnaire, they ran it on a simulator. They measured how much wear. They found out there was 0 wear. A couple of engineers said, why do we stop it at 15 million? Why do we do that? And so they just kept the machine running. And so after 30 million cycles, they tested it and remeasured it and found out that there was no wear. And other companies have tried to do that and haven't been able to reproduce it. So they have FDA approval to say potentially it's a 30-year knee. Now, there's a lot of variables that cause things to wear out sooner. You know, sometimes, I don't want to use the term rejected, but you know, sometimes bone becomes softer and the material does become loose in the joint. Sometimes things aren't in a good alignment, so making sure that they are in a good alignment can make it last longer.
So what you're saying is the knee replacement that she has now would not have to be removed? And
You would hope not, but I don't know how it was put in either. You know, and there's that variable. So, yeah, you know, certainly that's
then she could have this procedure that you're speaking of.
correct. Yeah, yeah, potentially, you know. I love to tell people that, you know, potentially this is going to last you a lifetime. You know, in the past, you know, I mean, the reality of life is that, you know, I'm 50, how old am I? I'm 53. You know, if you look at, you know, what Social Security sends me, they said I'm supposed to be dead at 84. That's my average life expectancy. So, you know, I should have 31 years left. You know, and there is some expectations. If I have we're doing implants on younger and younger people all the time, because part of that is a little push in that people aren't saying, well, when I first started in orthopedics, we'd say, oh, you can't have a knee replacement until you're 65. We can't do that. Because we wanted to tell people it was going to last them a lifetime. You know, we didn't really, I don't think we addressed what the pain issue was in the loss of mobility. Everybody's pushed that envelope a little bit, and they want to maintain that motion. They want to maintain their activity level. So we do implants, we do replacements on younger and younger people. So we've had to change and say, what is a better way to put it in? What's better materials to make them last longer? And that's what all this is about, is making things last longer.
You mentioned something about kneeling.
Mm-hmm.
Kneel, and with these you can kneel. And
Yeah,
things.
yeah. Oh, you know, that's the
I was
other.
able to kneel for 12 years.
Okay. Yeah, that's like somebody breaking their fingers and say, well, I ever played the piano again. They never played the piano to begin with. With the implant, there is nothing that stops someone from kneeling. And that was kind of a myth that was put out that, oh, once you have a knee replacement, you can never kneel again. You can. You aren't going to ruin the prosthesis by kneeling. That may be the case, yes. And there's other things that limit people from kneeling too. So, well, sometimes that's true. You know, sometimes you can't kneel beforehand, and you know, what are your abilities afterwards? Sometimes that's difficult.
Do you have to be put out completely, or can that area be numbed that you're going to be working with?
Give me 1 second to answer that.
Okay.
And I got a couple more.
Okay.
So when you consider a joint replacement, it's when conservative treatments fail. You know, when things fail to provide relief, then it's time to do something different. Then we shift gears. Stops your quality of life. You're not doing the things that you like to do. Pain that's unacceptable to you. When pain's unacceptable, then it's time to do something different. After seeing an orthopedic surgeon and making sure that this is the right thing to do. And educating yourself on options. Hopefully that's what we're doing here, is we're helping to educate you. The benefits, we know that we reduce the pain, enhance mobility, improve quality of life, return you to more normal activities. At Watervliet, we have the Center for Joint Replacement. We have a dedicated unit for joint replacements. It's a floor that we use just for our joint replacement patients. Dedicated staff. The OR crew that I use is the same OR crew I use for everything. They know exactly what needs to be done each step of the way. Our units Each unit or each room is private room. So, and they're considered live-in rooms. Our couch kind of folds out so people can stay with you during your whole stay. Our physical therapy and nursing staff, they kind of anticipate, they know what goals have to be met each day. My saying is a little bit of a kick in the butt to keep you moving in the right direction too. So, like I said, I have a skilled operating crew. The surgery that we do, typically we try to do it under spinal anesthetic. We make you go numb from the waist down, so you're not asleep. We do that, there's a couple reasons to do that. One is we block the pain fibers before we do the surgery. Blocking the pain fibers before you make the cut helps to reduce pain afterwards. Spinal anesthetic lasts longer, so that we're very comfortable that first night. We also do pain blocks. So there's nerve blocks, there's femoral nerve block, adductor canal blocks that the anesthetist injects at the end of the case so that the leg is numb for an extended period of time, so it reduces the pain afterwards. So those are things that we do to help with that pain immediately afterwards. And no, you don't have to go to sleep. Sometimes people do because of back issues, of having previous back surgery. So those are things that would stop a spinal anesthetic, and you would have to go to sleep.
We
So-
tried conservative remedies for a long time, and then what point do we get to that we can't have surgery?
Yeah. Well, so that's always an issue, and that's what you said too. Is that sometimes you come to a point that you can't have surgery, and if you do the conservative tooth and long, then it may negate having surgery because of other medical issues. When is it time for surgery? I can only tell you, you're going to be the one that knows when it's time for surgery. And it's when you're comfortable in saying that, I've failed conservative treatment. I've always felt that I've been conservative in my life and with things that I offer. And I offer all the conservative things. But, it comes to a point that if you have to have injections on a regular basis or, they're not taking care of the pain, there's other alternatives, and that's the surgical treatment. And, certainly I work with the cardiologist and the family doctors and the internist and pulmonologist in the area to make sure that things are adequate before surgery so that, we don't have a complication during surgery then. So we can kind of tune people up to make sure that everything's ready for surgery. Yes.
One injection, but it lasted about a year. And I'm at the point now, I think, do you get another injection?
Sometimes people choose to do that. Sometimes there is. And that's the injectables, that's the visco supplement, the thick fluid that we inject. Some of those can last up to 12 months. So sometimes people do have a repeat injection to the knee to last. Like I said, there's a correlation between how bad the arthritis is and how long it lasts. That if you do the injection and it only lasts for a few weeks, then it's not worthwhile to do. And eventually it comes to that point because we know that the disease is progressive. There isn't anything out there that reverses the arthritis. Yeah.
Can you back up a couple of those?
To where?
One more, right there.
Yep.
Low impact sports activity.
Yep.
What, give me a range of what I could do.
For low impact. Okay. So when we talk about activities, high impact activities, running. Running is a high impact activity. Low impact activity, being on, actually walking on a treadmill, jogging on a treadmill is low impact. Being on an elliptical, that is a low impact activity. Then we look at non-weight bearing or really extremely low impact activities. That's getting on a bicycle and swimming. Those are considered kind of non-weight bearing exercises. walking a golf course, playing 18 holes of golf. That's low impact. Tennis. So playing tennis. Playing singles tennis is considered high impact. Playing doubles in tennis is considered low impact. Go figure. But you know, it's not moving that distance on the court. But that's one of the things that are able to be done.
So dodgeball would be low impact?
Dodgeball could be low impact. Yeah. Yeah, pickleball. Pickleball is considered a low impact. Now, I played pickleball with one of the board members once, and man, that's not low impact what he's playing. I mean, these guys killed me. So it's you know, there is that range. If we're putting an implant in, you know, you don't want to pick up jogging and running. You want it to last as long as possible. So that's the lower impact things. There's a lot of things that are able to be done again.
How long has this new process been in place?
So doing Visionnaire has been in place now for 8 years, 9 years. When was your knee done? 10 years ago. Okay, so 10 plus years. Yeah. So you had Visionnaire done on your knee.
Any chance?
Yeah.
Any chance the body can reject this?
So no, the body doesn't reject the metal implants. You don't have to take anti-rejection medication after an implant. The only thing that we do is we have to give antibiotics for one to 2 years for dental cleanings, for having some procedures done for a year after an implant. That's the only thing that we have to do. But there's no rejection from the metal.
Chicken here. Do you ever do two at the same time so that somebody who just doesn't know that they'll go through it twice?
Yeah, okay. So I knew that was coming up after you mentioned it. Boy. So the only way that I will do a double knee replacement is, first, you have to have Visionnaire because we want to limit the amount of instruments that are in there. The second is I have to meet with you a couple times because you better convince me that you can go through a double knee replacement. It's a tough recovery. I think it's tough to recover from one. And recovering from two, yeah. There's a lot of people that say no problem, you know, and I think there's certainly people out there that can say no problem, but I think it's tough, and you got to convince me. You got to convince me that you can go through two, because if we make all the plans for recovery, I am not going to see you sit in a wheelchair or sit in bed after a knee replacement. No. Nope. There is, you talk about pop out, there's, so if you have a posterior stabilized knee, there's one that can jump the post and lock. So I know that can happen. The majority, so that's a whole different discussion. So there's surgeons that do cruciate retaining and do cruciate or posterior stabilized, where they sacrifice the ligaments. I'm a ligament saver. So I save the cruciate ligament, and by saving the posterior cruciate ligament, I don't put a post in, so they can't pop the post. So, yeah. Well, yeah, that's a whole different breed too, with a dislocating hip. But you can have one that pops out. Yes, sir.
Is there just the one company that has this Postma type knee replacement, and companies like Biomet, the other one down in Warsaw, still has just the one size fits all?
Yeah. So the companies that have patient specific. That's conformist. They're the only ones that have a patient-specific. For patient-matched, for making the cutting blocks that fit. So if you look at orthopedic companies, Smith & Nephew is a big company. They're based out of Memphis, Tennessee. Warsaw, Indiana seems to be the orthopedic capital of the world, and that you have Biomet, Zimmer, DePuy, which all started at DePuy. They all broke off because some executives got ticked off and created their own companies. Now it's Biomet Zimmer again, and DePuy got bought up by the other ones. So now they're all getting combined again. Biomet had a patient-specific. I got yanked off the market because they weren't following guidelines and things weren't specific. Theirs is coming back now. So they have what they call signature. And I don't use Biomet. I use Smith & Nephew. I like their Visionnaire. They're the only one that has the Viralast technology. They're the only one that can advertise 30 years. Now, if you talk another joint, shoulder, I use Biomet's shoulder. I like their shoulder much better. And that with their shoulder, I use patient-specific for that. And it's called the signature shoulder implant. So I do patient-matched implanting for the shoulder from Biomet. So each company does have a little bit of their own. Hopefully that long-winded answer.
Thank you. I had a doctor tell me I had to stall 5 to 15 years before I could have my knee replacement. He was a little older. Do you have a minimum age? Because I've been bone on bone for 5 years.
Do I have a minimum age? No, I guess I don't. I have a minimum wear criteria. How's that? So if you have enough disease to say you need a knee replacement, then you can have a knee replacement. I always hate giving ranges, but I have done knee replacements on people who were 21 years old, and I've done a person who was 98 years old. So I mean that's a big range, you know. And the 21, you know, definitely needed it because of the significant wear changes. And you know, for that we talk about needing revisions and needing other surgeries in the past when it wears out. You know, my 98-year-old gentleman that I did, he said that, you know, I don't care. I may live a year. I may live 6 months afterwards. But it's that amount of time that I don't have pain. He lived 4. So, and was happy with it that entire 4 years. So you don't know. But it all depends on the person's medical conditions and everything else also.
What's a typical length of surgery if things go as anticipated?
Typical length of surgery. So my typical length for knee replacement is 77 minutes. So that's the typical length of the surgical time, and that is from the time of making the incision to putting the bandage on. That's what kind of my average is. Yeah. What's that? This is not robotic surgery, no. So, you know, and I think that I've always said that Lakeland has done very well advertising the Da Vinci robot. And there is not, well, so there's not really a robot for orthopedics yet. And I got to back up and say there is a robotic arm that you can use for doing half a knee replacements. That robotic arm cost a little over 1.6 million. And it's not really cost effective. I know that they have one in Grand Rapids, and they used it 10 times. And so that's an expensive machine because it's too cumbersome, too awkward, and it doubled their operating room time to use the robot. So, there is a robot. This is computer planned. So you can hear of using a computer navigation during surgery. That's done frequently as we use a navigation unit. And that tells us the alignment kind of on the fly during the surgery. This is taking it one step further and planning it before I even make the cut. And it's kind of, I guess, my preferred way to make it patient specific, make it designed for you. What's that? Yeah, I think it is. We have to take advancements as they come, and this has become kind of a standard advancement now, is to make things last.
How much does it cost?
Oh, how much does it cost? I don't know. I don't know. I know that the custom implants are about the same as what a standard replacement is. They don't make an upcharge for it. The company has done a very good job in figuring out how to make a custom implant. For the Visionnaire cutting block, yeah, it costs a little bit more up front because I have to get this done, What offsets the cost from the other is that typically when I do a knee replacement, there's six trays of instruments that have to be opened. Each of those trays have to be washed, they have to be sterilized, they have to be checked. There has to be room to have all those open. When I do Visionnaire, it's all packed into one tray. So there's less cleaning, less sterilization. When they count sterilization, it costs a lot to sterilize a tray of instruments. I can't remember what the number is, but it's a relatively high cost. So, when you compare bottom lines of things, it all washes pretty even.
This one has a question. I don't want to mess up this question.
Yeah.
Is there any relationship toward having gout and being treated for that and left with arthritis in the knee?
That kind of brings up the point. Once you have a knee replacement, it removes the arthritis. Okay, so the arthritic portion is gone. You can't have arthritis to a joint that's not a joint anymore. So you can't be left with anything. Now, with having gout, having rheumatoid arthritis, those things affect joint lining, and so you can still get inflammation to the joint, but it can't affect the weight bearing, can't affect the motion of the joint.
Does it affect the back area, like can you get your back from all of this?
So gout from arthritis?
The arthritis in the kneecaps and all of that?
Yeah, those type of, any type of arthritis can affect other joint areas, being the back, being elbows, being finger joints. Yes?
Once you make a decision to get this done, what's the procedure then?
So once a decision is done, it's a matter of kind of scheduling. When I do the custom or patient specific, it's a matter of us submitting the form to the company saying that we're going to get either a CT or MRI or the x-rays are going to be sent. And we start submitting that. So we schedule for the MRI. Sometimes the company can be really good and turn things around quickly. I just did one Tuesday and everything was submitted and there was a problem with an x-ray and we couldn't get a hold of the person to get the x-ray repeated until Thursday last week. And on Wednesday, we had the patient come in, get the x-ray. We sent it to the company. They quick matched everything. I verified everything Thursday night. They ran the batch Friday, and the laser screwed up, and it screwed up 50 50 implants, and so they came back in Saturday, they did it, and they sterilized it, they FedExed it to me, and it arrived at 10 a.m. on Tuesday for her surgery. So, you know, that was a rapid turnaround of 4 days. So we always plan 6 weeks for the turnaround.
Are you taking any new patients?
I'm always taking new patients. This is our contact information. Luce, one of my assistants, she's actually in the hall that can help schedule a patient. She's right in the back of the room there. She heard her name. So talk to Luce if you'd like to schedule an appointment. She would be glad to put you on my schedule to see me and talk to me about this. So it's where the pain is and what the x-rays look like. Yep. So if somebody says it hurts all over the knee, it hurts over the entire knee, and I can't pinpoint an area, then it's probably a total knee replacement. If somebody comes in and is pretty specific on where the pain is, then I can kind of narrow that down to a partial replacement.
Once you're released from the hospital, are you able to go home and take care of yourself? 'Cause all my family have been anywhere.
And I think that's a dilemma that we always have to kind of work through. You know, taking care of yourself, going home afterwards. Medicare has kind of pushed to 2-3 day stay, and that's kind of standard after knee replacement, 2 to 3 days. I think people need extra help for a couple of days afterwards. So having extra help for a few days afterwards makes a big difference. And sometimes we rely on what we call subacute nursing. You know, a lot of the nursing homes, what were used to be nursing homes, you know, we're of a generation that you think of a nursing home, you walked in the door, you left through the back door. Most nursing homes have a revolving door in the front door now that, you know, 80% of the people that go into a nursing home walk out the front door. They use them for rehab. And it's subacute rehab. You know, they have physical therapy that works with them. So we look at extended stays at a nursing facility to help with that. If somebody my routine is that typically after a joint replacement, after you go home, I use home care for home physical therapy for the first 2 weeks. Because I think for the first 2 weeks, it's difficult to get in and out of home and do things. So we use a home care with home physical therapy to kind of check on you. And they come in 3 days, 4 days a week to check on you at home. And then we get you to outpatient physical therapy after that. Yeah, so one of the other things is we use a continuous passive motion machine that helps with the range of motion to the knee immediately afterwards. People love them or hate them.
Both knees done, you're on one almost continually.
Yeah.
Do you do any other kind of surgery, like shoulder surgery?
Yes, yep. I do. I'm a general orthopedic surgeon, so I do everything from carpal tunnels to trigger fingers to rotator cuff repairs to shoulder replacements to knee scopes to hip and shoulder. Yeah, yep. So I do all those things.
Okay.
I'll be up here if people have other questions afterwards. Thank you very much for coming and spending an hour with me tonight.
Thank you.